from the American Academy of Pediatrics.
The AAP is pushing for foundational reforms to Medicaid and the Children's Health Insurance Program, or CHIP.
The goal? To improve access and reduce disparities.
We really need to have fair payment for all children's services so that we can continue to offer high-quality care to all kids.
We have an obligation as pediatricians to look towards equity in a future for children and their families where they have equal opportunity.
But first, it's November, and that means it's time for everyone's favorite research roundup from the journal Pediatrics.
Parents are just trying to navigate this the best that they can. They do want to hear what we have to say, and they are looking for reputable and reliable information.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with this month's edition of First Up.
I cannot believe it's November. Fall is in full force. What are your Thanksgiving plans, Joanna? Is it your due date coming up?
I'm planning on staying within driving distance of Philadelphia, just in case, but not hoping to deliver until the end of December. That'll be much closer to my due date.
Whew, I'll be thinking of you throughout this holiday season. You know what else is at the top of my mind? And this is all the pediatrician in me, but I'm hoping everyone who gets together in large indoor groups for the holidays is vaccinated.
As a pediatrician and a pregnant lady, I'm hoping that too. And I know someone who is fully vaccinated and whom I'd love to have at the family table with me to talk about infection prevention. Dr. Rachel Moon, the Associate Editor of Digital Media for the journal Pediatrics.
Is that really what you talk about at the family table? All right. Dr. Moon is also someone who can talk about so many more things than just vaccines. Rachel, good to have you on for this month's edition of First Up.
Thank you. And I do have to say, I am fully vaccinated. So I'll come over anytime, Joanna, if you're going to cook for me.
I knew it. Well, let's start by talking about vaccines then, because I've been wondering how much COVID may have either boosted or eroded trust in vaccines. Do we now have data on how the pandemic has changed attitudes on vaccines?
So that is a really great question because there has been so much concern amongst pediatricians and the medical community in general that all of the misinformation and the hesitancy and the politicization of the COVID vaccine particularly might translate into more widespread hesitancy about vaccines in general. So this month we have an article from the University of Colorado and the Colorado Department of Public Health, and the author Dr. David Higgins and his colleagues, they analyzed data from the Healthy Moms Survey, which is a longitudinal survey of Colorado birthing parents. And they found that 20% of these parents were vaccine hesitant, and this was consistent with the numbers that were pre-pandemic. So they did not see an increase, which is a good thing. However, they found that parents post-pandemic were more likely to be unsure if they could trust vaccine information. And I think that that is definitely a result of all of the conflicting information out there.
Well, it's good to know about our routine childhood vaccinations, but is there more specific information on the COVID-19 vaccine itself? What is the uptake looking like on that?
Funny you should ask, David, because we happen to have an article about that as well.
Oh, good.
Yes, and Aubrey Hahn-Koop at the University of Nebraska and colleagues from 9 other U.S. institutions, they conducted focus groups with parents about COVID vaccine specifically. And they intentionally recruited groups who had been disproportionately affected by COVID vaccine hesitancy. So this included people who lived in rural communities, who identified as Black, or who were Spanish-speaking. And these parents, they expressed a lot of concern about unspecified long-term effects. So they weren't sure what these effects might be, but they talked about infertility and they talked about potential effects on child development. And then a common theme among parents whose first language was Spanish in particular was that they wanted to wait until there was more data. So they thought that it was too soon to give their children this vaccine. So for those of us who talk to parents in our practices, I think that these themes reflect what we have heard. And one good thing is that nearly all of the participants said that they would listen to what their child's doctor said about COVID vaccine. And almost universally, they expressed distrust or mistrust of information that they were getting from social media, unless it was social media from health institutions. So I think that the take-home messages from these two articles are that there is a lot of conflicting information out there, and parents are just trying to navigate this the best that they can. They do want to hear what we have to say, and they are looking for reputable and reliable information. So we shouldn't be afraid to talk about vaccines and to ask about what parent-specific concerns are. And I think that we need to continue giving strong recommendations for vaccines.
And it's so nice to know that parents are still trusting our advice and asking their pediatricians too. And I'm hoping everyone considers updating their vaccines, especially getting flu and COVID, before the holidays. And Rachel, since you are podcast family and feel comfortable talking about anything in pediatrics, let's shift focus to something we've also covered on the podcast, e-cigarettes and vaping. We have talked about the rise in use of e-cigarettes, but if we as pediatricians want to help kids quit, what tools should we be using?
So that is an interesting question, Joanna, because we know that the use of these e-cigarettes among adolescents has rapidly increased. And so it's hard to know what kind of guidance do we provide besides just saying you should quit. And what do adolescents do when they want to quit? Daisy Day, PhD, and colleagues from the University of Nebraska, Kansas City University, and Harvard University analyzed data from the 2021 National Youth Tobacco Survey to answer these questions. So of the 1,400 students who reported vaping currently, 2/3 of them had tried to quit in the past year. That in and of itself is interesting because studies have shown that most adolescents don't even try to quit unless they are worried that they might be addicted to the e-cigarettes. 63% of the adolescents who had tried to quit reported that they didn't use any resources. They just tried to quit cold turkey. But the most commonly reported strategies that were reported included peer support, that was 14%. 6% looked for help on the internet. 6% downloaded a mobile app or a text messaging app to help them. And 6% got support from their parents. Fewer than 4% reported getting any kind of quit support from a doctor. The vapers who identified as being male or Hispanic were less likely to report that they had tried to quit without any help, and they were more likely to ask for help from their parents, interestingly. And those who reported being gay or lesbian were also less likely to report quit attempts without any help. So the few takeaways that I have from this article are that we need to ask our patients if they're vaping. And for those who deny being addicted, we might gently suggest that they try not to vape for a couple of days because this might convince them that they are addicted and that they need to quit. There are actually very few evidence-based vaping cessation programs specifically developed for adolescents. So for now, I think that we have to largely rely on programs that have been developed for adults. I've been referring my patients to the Quit line, so that's 1-800-QUIT-NOW, which offers support for those who use e-cigarettes. And for those who are digitally inclined, like many of our adolescent patients, there's a Quit Start app, which was developed by smokefree.gov and the FDA, which may be a helpful resource for them.
Well, I'm a huge fan of the Quit line for my patients and for my parents, so I'm glad you brought that up. While pediatrician support wasn't one of the top 4 ways kids try to quit e-cigarettes, pediatricians are advocating for so many things. One of those things is making referrals easier for patients, particularly when those patients have common issues like autism. What initiatives are going to make it easier for pediatricians to get their patients services?
That's a great question, because on this podcast, we have talked several times about the baseline difficulties that children with autism have with getting a diagnosis and then accessing services and support, and then the racial and the socioeconomic disparities that are layered on top of that. So a multidisciplinary team at Children's National and stakeholders in the Washington, D.C. community came together to try to address these multiple barriers that are faced by these children. So this team, who is led by Serena Habayeb, PhD, provides us with a blueprint of what they did in an advocacy case report. And as an aside, I just want to put in a plug for these advocacy case reports. These describe specific efforts in child advocacy that can result in systems change and have positive effects on children. And a lot of these efforts are ones that can be implemented in other communities. But back to the issue of autism care in Washington, D.C. This team brought together stakeholders from the medical community, the mental health community, parents, educators, insurance companies, and governmental agencies. And one of the barriers that they identified was the long wait time to see a developmental specialist to even get a diagnosis of autism for their child. So they developed trainings and toolkits for primary care providers, and they have started embedding specialists in primary care sites to see these patients. And then they also worked with regulatory agencies to expand the different types of behavioral health care providers who can become credentialed with DC Medicaid and then bill for these services. And then they also provide care coordination and support to families after the child has been evaluated. And it's very impressive to read their results. They've decreased the wait time for evaluation, and children in DC are being diagnosed with autism at earlier ages than the national norm. So these are all big, big wins. And they've also focused many of these efforts in primary care centers that have large populations of patients who are Black, Latino, or who speak a language other than English. So this is incredibly important as well. So I hope that our listeners will look at the details of this advocacy case report and maybe get some ideas of how we can all improve processes for getting children evaluated earlier when there's concern for autism.
So, Rachel, thanks for joining us on the microphone today. We had you review 4 articles, which is a lot, but I could think of a 5th one that's coming out this November.
Yes, so I get to turn the tables now and ask the two of you about an article that's also in this month's issue of Pediatrics. And it's an article that the two of you are both authors on about the utility of podcasts in medical education. So I'm going to pretend to be David and Joanna and say, can you give us your takeaways for this article?
Sure, Rachel, I can start. And that is that, podcasts are already being used by a lot of trainees in medicine, and not even just trainees, other doctors. And so, I think David and David will give his takeaway in a minute, just really want to enforce that podcasts can be a really useful part of medical education. And we need to be finding ways to integrate them more into curriculum instead of having them just be something extra that people are doing to educate themselves.
Yeah, I would say we were almost juniors on this article. Many of our co-authors have been doing this much longer than Joanna and I have, and many of them give CME credit for their work. So we just really wanted a chance to look back and think, oh my gosh, we've been doing this for 20 years now?
20 years.
Maybe longer, depending on how you count it. And people keep talking about this as a new and emerging means of medical education. But honestly, it's fairly mature and getting more mature every day, not unlike me.
You want a little inside ball, Rachel, actually? Is we tried to make this pickleball analogy when we first wrote the article, being like, podcasts aren't tennis, they're pickleball. But that did not work.
No. And we want to thank the editors. We want to thank the editors of Pediatrics for steering us away from that awkward analogy.
Well, yeah, and also for people who don't play pickleball is incredibly annoying, and you don't want to give the impression that the podcasts are annoying.
No.
And if you talk to any of our trainees, so many of them are using podcasts on a daily basis. So kudos to the two of you.
Thank you.
Thank you so much, Rachel. There you go. 5 articles, which is a lot. Do you have any time to unwind this holiday season?
I think so. I hope so. Yes, so we will be spending time with family, and I think that I am looking forward to that. And then actually, I'm going to brag a little bit. Our older daughter is defending her dissertation the week after Thanksgiving. And so we're going to go out to California for that. And then we're going to spend a little vacation time there too.
Nice. That sounds magnificent in so many ways. Dr. Rachel Moon, thank you for joining us today.
Thank you for having me.
To read these articles and more, go to aap.org/podcast.
Coming up, we'll look at a new policy statement recommending reforms to Medicaid and CHIP.
Okay, Joanna, let's say you wanted to do one thing to improve child health for the next generation. What would you choose?
That is a tough one. Of course, I would probably find a way to prevent preterm birth and likely think of ways to address climate change, as I see that as a threat not only to the planet, but to our children as well.
Oh, those would be great. But have you considered the impact that expanding and standardizing Medicaid and the Children's Health Insurance Program, or CHIP, might have for kids in the future?
Yes, those programs already provide coverage for around half of U.S. children, but they're a complete patchwork. And we talked in episode 156 about the risks to families from Medicaid unwinding. But how big a difference would it make, and where would you start?
Well, honestly, I don't know. That's why today we have two guests who can tell us more. Dr. Jenni Kusma and Dr. Raphael, both authors on a new policy statement for the AAP, Medicaid and the Children's Health Insurance Program, optimization to promote equity in child and young adult health.
Dr. Raphael serves as a professor of general academic pediatrics at the Baylor College of Medicine.
And Dr. Kusma is an attending physician in advanced general pediatrics and primary care at the Ann and Robert H. Lurie Children's Hospital of Chicago and an assistant professor of pediatrics at the Northwestern University Feinberg School of Medicine. Jenni, welcome.
Thank you.
Thank you.
All right, perhaps we can start with a history of these programs. How do they fund healthcare for children, and is the oversight mostly federal, like it is with Medicare?
Sure. So the history of the programs in terms of Medicaid and CHIP. So Medicaid started in the 1960s along with Medicare. So where Medicare was designated for people who are 65 and older, Medicaid was designed to serve people who were indigent, which was the term used back then, but really today would be considered low income. So for decades, Medicaid did that service and really provided services for those who were underserved in that way. And then into the 1990s, there was this recognition that we needed another form of insurance for children, additionally, for those who didn't meet the eligibility requirements for Medicaid. So that's where the Children's Health Insurance Program came in, again, providing another mechanism of coverage for children. And there are a number of similarities between both in the sense that they provide a number of services and benefits for children. Medicaid is an entitlement program where there is funding both at the federal level and at the state level. And depending on state to state, the federal match for Medicaid could be anywhere between 50% and 77%. And what that allows is that some floor in terms of benefits, eligibility, but also allows for state variation in terms of states also being invested in terms of innovating above and beyond what is set as the floor.
I think that the important distinction, too, is remembering that while some states have combined these programs, in some states they're different. And to answer that question with the federal oversight versus state oversight, there's a lot of flexibility in the state. So it's a shared program. They both pay into it. So unlike Medicare, that's a fully federal program. In today's world, the Medicaid and CHIP programs are both paid by both and really largely determined by the state how it's implemented.
With states playing such a fundamental role in interpreting the benefits to children from Medicaid and CHIP, are there places that have comprehensively funded children's health care? And if so, how?
I think we can think of at least two examples of states that have innovated in ways that have improved or given more coverage or eligibility for children in their states. So these are states that have come up with innovations in the Medicaid and CHIP program to really help the children in their state. One example is Oregon, who has extended eligibility through legislation for children from the ages of 0 to 6 years old. These children now don't have to reapply for Medicaid or CHIP in that period. They have continuous eligibility from the age of 0 to 6 years, which is fantastic. That means these children aren't falling off of Medicaid and having to get back on it, and CHIP.
Another great example is in Tennessee, where they've started to cover dyadic care. And that's such a great innovation because it recognizes that children occur within the context of their families. So taking care of the parents, recognizing all the family needs in the context of that child's care really gives an opportunity to really think about whole family care, and that supports the child and leads to better outcomes overall.
It's so interesting to hear about states that have done things right, but I have to think it's also rare. And given different state interpretations of the law, are there equity issues with how these programs are currently managed?
Absolutely. So I think the way Medicaid was designed was to really allow some flexibility at the state level because in theory, the state knows its residents' needs. So there's a lot of potential for good that way, but there's also potential for inequities because there may be different interpretations of eligibility, enrollment, benefits, what's covered, how reimbursement works. And so that's where you may see inequities. And as states do their different things, you may then see inequities between states as well. So what a child experiences in Illinois may look different from what a child experiences in Florida or Texas. And that's where these inequities start to propagate.
So at this policy statement, the AAP is now suggesting ways these forms of public insurance could be restructured to address those inequities in coverage that you brought up. Let's start with eligibility for Medicaid and CHIP. Who should be entitled to get it?
So in this policy statement, we propose foundational changes to what we think our vision for a Medicaid and CHIP program in the future. And as far as eligibility goes, we think that all children in the United States should have the option to be eligible for a public health insurance program. We think that there should be automatic enrollment of newborns with the option to opt out of that program. And we think that coverage should be extended up to the age of 26 years.
And what about getting on Medicaid and then losing it, as we've seen with this whole unwinding situation?
One of the proposed changes in this policy statement is that we would have extended periods of eligibility. So like we just mentioned with Oregon, continuous eligibility from 0 to 6 years old, that would allow children to remain covered for 6 years. We also think that there should be extended windows. We mentioned in the policy statement 2 years. I think if states want to have longer periods, that would be great, but a minimum period of 2 years where children would continue to be enrolled in Medicaid, which would help with these issues we're seeing with the unwinding where people are falling off of their health insurance coverage.
And just to add to that, I think why that continuous coverage is so important, you think about the families we're trying to help. These are the most vulnerable families that we have, both socially, economically. And so think about the burden of trying to constantly apply and reapply, the health literacy that is involved in trying to read these applications, produce all the required documents as well. That's a huge burden on people who are already having the competing interest of trying to make do with their families and trying to achieve everything so their child or children do have good health.
And what about geographic issues? Where I live in North Carolina, we get kids come in from South Carolina, Virginia, Tennessee, and the moment they cross the state line, they lose their Medicaid coverage. Is that a thing that we could maybe fix?
One of the things we'd like to propose a solution in this policy statement is a more federally funded program, which would allow for more standardization across states. Exactly to your point, there's many children who have to travel across state lines for primary care, for subspecialty care. Their closest hospital may not be within their own state. And we need a more standardized program so that a child can cross that state line and still have access to quality coverage.
We see the same thing in Philadelphia because we get a lot of referrals to the Children's Hospital of Philadelphia, so thank you for that. And another strategy that could address the variation in Medicaid and CHIP could be the ability to streamline the services and supports children receive. Are there any strategies to get states to align with what care should be covered for children?
Absolutely. So we have something called EPSDT, which is a benefit for children who are, from 0 to 21 in terms of, periodic screening, diagnostics, treatment that all children should be entitled to under Medicaid. And that's the standardization that we think of. There is some flexibility in states, how states tend to interpret that. And I think what this policy statement offers is really making it more of a firm commitment, both in Medicaid as well as CHIP, to follow EPSDT, so that children in Florida versus Oregon versus Michigan all experience the same child benefit when it comes to healthcare services.
And really hoping that this definition will be more consistent by having it shift to a more federal program. So it will leave less interpretation to states on how they'd want to implement those benefits by having more federal oversight of the program.
That is a fantastic observation, because in the AAP's vision for this transformation, which I have to say is incredibly exciting, who is footing the bill? Is this going to become just a federal program?
No, not whatsoever. I think the goal is to increase the floor of what benefit can occur if you have mostly federal funding, so that we can say, here are the standards that we think will make for an equitable program. So children in different states see the same things, family experience the same things, and in terms of benefits, in terms of who they're allowed to see and subspecialists. In terms of footing the bill, I think we'll still have some portion that the states have to account for in terms of funding all of this. And that will still give them the incentive to innovate at the state level, to think about their specific residents and what kind of innovations of Medicaid or CHIP that they can create. Ideally, we'd like to see, again, Medicaid and CHIP combined to minimize that variation. So it will still be a combination of the federal versus the state. It would just be the federal component would rise in order to increase the floor and just standardization across the board.
Do you think we have a realistic chance of getting some of these policies and changes passed? Which one should pediatricians be advocating for at the state and also the federal level?
One of the goals of the policy statement was to promote both foundational changes, right? What's the vision? What are the big dreams for what the Medicaid and CHIP program could look like, while also presenting incremental goals or incremental steps that we could be taking now to help the program be more accessible, be more equitable across the programs. Some of those steps include advocating at the state level for the coverages that may or may not be already being covered at your state, such as benefits that should be under EPSDT that may or may not be. You may have patients that you see aren't getting the services that they need. That's one step towards more equitable coverage and more equitable access.
I would add as well is that, funding is a big issue. That's also something we try to cover in the policy statement. So the reimbursement for Medicaid, and specifically for children, is just not on par with what we see for reimbursement for adults. And that historically has been a major and significant issue for the care of children. And so increasing the reimbursement for Medicaid for children's services is a big part of this vision. And that is something definitely that pediatricians can advocate for. So having Medicaid reimbursement more on par with Medicare would definitely be something that pediatricians can advocate for in a very specific way. Equity is something we talk about. And as Dr. Kusma and I have talked about today, there are so many areas where we can start to address Medicaid by reducing variation across states, making sure that people see the same version of Medicaid wherever they are. And then also just enrollment, decreasing the barriers that families encounter in terms of getting coverage and maintaining coverage over time. So all of those areas, I think pediatricians can definitely get behind and go out and advocate tomorrow for.
And currently, I know of different hospitals and pediatric practices that don't take Medicaid because it's too difficult for them to figure out the reimbursements. Are there ways in which these hospitals and clinics could more easily incorporate Medicaid into their practices?
One of the foundational changes we call for in the policy statement is increasing the funding for the Medicaid program, increasing it to match more of that funding we see on the Medicare side or the commercial insurance side. And what that will allow is these practices that don't take Medicaid or hospitals that don't take Medicaid to hopefully be able to take more patients from the public health insurance program. We know that access is an issue. If these practices can't take Medicaid and CHIP because of the low reimbursement rate, then these children have further distances they need to travel for care, which is an access problem. So funding these programs adequately will really help more children have that access and in that proximity that they need to have better care.
Well, this is such a thorough and compelling policy statement. I really hope all of our listeners are going to read it for themselves. But is it possible for each of you to leave us with one takeaway?
I think if any takeaway from this policy statement is we have an obligation as pediatricians to look towards equity in a future for children and their families where they have equal opportunity to succeed. And I think what this policy statement really does is provide the vision to do that and the tangible steps to do that. So my one takeaway is equity has to be the goal. And as we look at all the different strategies, both foundational as well as short term, I think they all drive towards equity. So to me, that's the North Star that I take away from this policy statement.
Echoing those sentiments, if we think about all the benefits that there are from public health insurance and from the Medicaid and CHIP program today, this policy statement is really meant to make this program the best it can be for all children. And I think in doing so, we really need it to be equitable. And in order for it to be equitable, it can't be different if you walk from one state to another. And we really need to end that state variation. We really need to have fair payment for all children's services so that we can continue to offer high quality care to all kids. And so this statement really is making this a strong public health insurance program for all children.
And we want to thank you for your strong voices in this, Dr. Jean Raphael and Dr. Jenni Kusma. Thank you so much for talking with us today.
Thank you.
Yeah, thank you.
To read the policy statement, Medicaid and the Children's Health Insurance Program, Optimization to Promote Equity in Child and Young Adult Health, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what is your Say Ah this week?
Well, Joanna, as you know, it's been kind of a tough week, and often when we're going through something difficult, I still like to figure out what about it is positive or enlightening. My wife's stepfather died suddenly last week at the age of 88, and that is neither positive nor enlightening, but we have had this outpouring of love and support starting at my own practice, which covered me to go home without warning, and then extending to neighbors, family members, neighbors of her stepfather who have come forward to share their memories and thoughts about him. And so I guess those are kind of the stars that I'm finding in the dark sky right now. And that's a tough pivot, but give me something about children and your life, because that's so much fun.
I just want to say before I go into my Say Ah, David, that I am thinking about your family a lot and sending you a lot of love.
Well,
and
you.
I'm so glad that is helping you get through this really difficult time.
There's always a star somewhere.
My Say Ah, I will make it about my kids. You know, we had a recent holiday. It was Halloween.
Yay!
And it's still really fun for me to be trick-or-treating with my kids and putting them in costume. And actually, I know some parents find it stressful, but I find it really just like a great time, in part because Philadelphia has such a fun Halloween scene. So I'm just taking all these memories of my kids actually wanting to trick-or-treat with me.
That's the best.
And taking them forward another year.
Oh, that is great. So I miss that. That was fun. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about so-called older infant, young child formulas.
We'll speak with the first author of a new clinical report, Dr. George Fuchs. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.